This is Jay Kaplan, and I'm going to talk with you today about the evidence behind the target guidelines in the treatment of patients with the complaint of low back pain and with the diagnosis of sinusitis. This grand rounds is given on behalf of the Louisiana Quality Network and the Medicaid Managed Care Incentive Payment Project. In particular, the committee focused on promoting evidence-based practice and reducing low-value care. In the first grand rounds, we talked about the general concept, a primer of what is evidence-based practice. And we just mentioned the two guidelines. The two guidelines which have been chosen by our committee for implementation inside the Louisiana Quality Network include reducing unnecessary imaging in patients with low back pain and reducing unnecessary prescribing of antibiotics in patients with a diagnosis of sinusitis or rhinosinusitis. Today, we're going to, in fact, talk about what is the evidence and why are we going about doing that. Now, in the first place, let's just review what is evidence-based practice. And what is evidence-based medicine? It is the integration of the best research evidence with clinical expertise and with patient values. And the whole point is better clinical outcomes. What our task is really is to develop strategies to assess the quality of evidence for health claims effectiveness and applicability, since practice is usually based either on evidence or it's based on expert consensus, which may or may not be consistent with what evidence-based practice is. Now, Choosing Wisely is a campaign that was an initiative initially of the American Board of Internal Medicine Foundation, and its purpose was to advance a national dialogue on avoiding unnecessary tests, treatments, and procedures. More than 80 specialty societies have identified commonly used tests, treatments, and procedures within their specialties whose necessity should be questioned or discussed between physician and patient. Two such categories are those that I just mentioned, avoiding lumbar spine imaging in the emergency department in adults with atraumatic or non-traumatic back pain, unless the patient has some complicating medical condition, and avoiding prescribing antibiotics for patients with viral sinusitis who do not have evidence of secondary bacterial infection. Let's talk first about diagnosis and treatment of low back pain in the emergency department. And what I'm going to present to you is an evidence-based approach that's appropriate for most patients, and the truth be known is that it does and may at times need to be adapted to meet the needs of individual patients and situations. It does not replace clinical judgment. Now, the measured description is the percentage of patients with a primary diagnosis of low back pain who did not have an imaging study that's either plain X-ray, MRI, or CT scan within 28 days of diagnosis. The numerator is those patients who received an imaging study, and the denominator is all patients 18 and older with the principal diagnosis of low back pain. Exclusions are for patients with complicating medical conditions such as cancer, recent IV drug abuse, trauma, neurologic impairment, HIV, spinal infection, major organ transplant, or prolonged use of corticosteroids. Now, it's estimated by the NCQA that 29.9% of patients presenting to an emergency department with a complaint of nonspecific low back pain, in fact, received an imaging study. There are a number of specialty societies that have incorporated this particular guideline in their specialty recommendations. There are actually 6. We're focused here on avoiding lumbar spine imaging in the emergency department, and that is put forward by the American College of Emergency Physicians. The American Academy of Family Physicians says don't do imaging for low back pain within the first 6 weeks unless there are red flags. The American Association of Neurologic Surgeons and the Congress of Neurologic Surgeons indicates don't obtain imaging of the spine in patients with nonspecific low back pain and without red flags. The same is true for the American College of Physicians. The American College of Occupational and Environmental Medicine says don't initially obtain x-rays for injured workers with acute nonspecific low back pain. And the North American Spine Society focuses more on advanced imaging and says don't do that within the first 6 weeks. Now, if we look at the research, this is a note from an article published in the Annals of Internal Medicine in February 2011. And in this, they note that low back pain is very common. Many patients with low back pain receive routine spinal imaging, despite the call that it's unnecessary. Routine imaging does not seem to improve clinical outcomes and exposes patients to unnecessary harm. So let's look at what they looked at. They looked at cost. And in 1988, the total US healthcare expenditures for low back pain were estimated at $90 billion. Average total health expenditures were almost $5,000 per year for patients, and over $6,000 in 2005, which was an inflation-adjusted increase of 65%. This rate was higher than that observed for all healthcare expenditures. And there are also a lot of indirect costs due to lost productivity in terms of obtaining those studies. Therefore, reducing unnecessary tests or ineffective treatments is an obvious way to decrease the costs. And if you look at the cost of low back pain imaging, I know the type is small. However, it does note that for lumbar spine imaging, it's $204 to $286 in network, and double that almost in out-of-network. Lumbar spine computed tomography is over $1,000 to $1,500, or almost double that for out-of-network. And MRI is similar, although perhaps in this study slightly less than CT. If you look at potential harm, here's what you find. That lumbar radiography, that is diagnostic plane imaging, is done much more frequently than CT, and therefore it accounts for a greater proportion of the total radiation dose from medical imaging procedures, despite having a lower average effective radiation dose. However, if you look at it, the average radiation exposure from lumbar radiography is 75 times higher than for a chest X-ray. And this is a particular concern in young women because of the proximity to the ovaries, which are difficult to effectively shield. And the amount of female gonadal irradiation from lumbar radiography has been estimated as equivalent to having chest radiography daily for several years. That's rather astounding. Other reasons: most lumbar imaging abnormalities are common in persons without low back pain and are only loosely associated with back syndromes or back symptoms. The many abnormalities are so common in asymptomatic persons they could be viewed as normal signs of aging. And most patients with acute low back pain, with or without radiculopathy, have substantial improvements in pain and function in the first 4 weeks, and therefore routine imaging was unlikely to improve on this. Now, there was a review in Lancet in 2009, which again noted that some clinicians do lumbar imaging routinely. So they analyzed randomized controlled trials that compared immediate lumbar imaging versus usual clinical care without immediate imaging. They reported pain or function as a primary outcome, quality of life, mental health, patient-reported improvement, and patient satisfaction in the care. There were 6 trials which met the admission criteria, and their study quality was independently assessed. They did not record their findings. They did not record any significant differences between immediate lumbar imaging and usual care without immediate imaging for primary outcomes at either short-term or long-term. Other outcomes did not differ significantly, and therefore they felt that their results were applicable to acute or subacute low back pain assessed in primary care settings. Their conclusion was that lumbar imaging for low back pain without indications of serious underlying conditions does not improve clinical outcomes. Now, I'll also reference the European guidelines for the management of acute nonspecific low back pain in primary care. This is an excellent reference, which sort of puts together what we just talked about. Their summary of recommendations for diagnosis of acute nonspecific low back pain. Diagnostic imaging tests are not routinely indicated for nonspecific low back pain, and I've highlighted that. If history indicates possible serious spinal pathology or nerve root syndrome, a more extensive physical exam is warranted, including neurologic screening, and then times of reassessment. And then they make recommendations with regard to treatment of nonspecific low back pain. So there is this algorithm that we could well post on the walls in our emergency departments, and for that matter, it could be in primary care offices as well. If a patient presents with low back pain, you do a history and a physical exam. If there are no red flags, you look for focal neurologic symptoms such as true low motor weakness. If there are none, you look for lumbar radiculopathy. And if that isn't present, then the treatment is noted there, which is education and insurance, activity, and medications. The first line being acetaminophen or nonsteroidal anti-inflammatory medications, and the second line being muscle relaxants. If there are red flags, evaluate for serious pathology. If there's true lower motor weakness, consider imaging and emergent surgical or neurosurgical consultation or neurologic consultation. And if there's lumbar radiculopathy without motor weakness, consider a referral to a specialist. There are notes on the right-hand side of this. And then here are different red flags for serious pathology. And you can see they include those categories that I mentioned before in terms of suspected cauda equina, upper motor neuron changes consistent with a myelopathy, recent trauma, suspected compression fracture, cancer, or suspected infection. So the summary of key points, imaging is not generally needed to diagnose low back pain. Imaging tests can lead to expensive, unnecessary interventions, and the radiation is not insignificant. An abnormal imaging study does not mean that a patient's pain is due to the identified abnormality, and up to 50% of patients will have an abnormal finding if you do an image. Red flags can certainly be identified through patient history and physical exam. 90% of patients will respond to conservative treatment, and unless contraindicated, the first line is acetaminophen or nonsteroidal anti-inflammatory. Physical therapy can also be extraordinarily helpful. Now, finally, common therapeutic modalities, walking and aerobic exercises, core strengthening exercises, since we know that abdominal wall strength can directly affect how a person carries himself or herself and can affect the lower back strength. End range flexion extension, yoga, Pilates, aquatic exercise can all be very helpful. And here are the references that are from some of the Choosing Wisely, the specialty societies which make the recommendations. And here are some of the references that are otherwise included in the previous presentation. Now let's talk a little bit about avoid prescribing antibiotics in the emergency department for uncomplicated sinusitis. Again, this needs to be individualized and does not replace clinician's judgment. Acute viral sinusitis, here is the definition. Rhinosinusitis is preferred to sinusitis since inflammation of the sinuses rarely occurs without concurrent inflammation of the nasal passages. As noted, the most common etiology is viral infection. Symptomatic management usually resolves within 7 to 10 days. Bacterial infection only in 0.5 to 2% of cases. Now, acute bacterial rhinosinusitis may also be self-limited, and patients may be treated symptomatically or observed. Rarely will they develop serious complications. Treatment is supportive care, since there are no specific treatments that shorten the course of the disease. Even if it doesn't resolve in 10 days, it is expected to improve. and those that fail to improve at all after greater than 10 days of symptomatic management are more likely to have acute bacterial rhinosinusitis, or ABRS. To differentiate the definition, even those with acute bacterial rhinosinusitis have self-limited disease. Rarely will it develop into a serious bacterial infection, and patients treated with antibiotics may have a shorter course, but also more adverse events. This is a study, Antibiotics for Acute Rhinosinusitis in Adults. It was a study where they searched the Cochrane Acute Respiratory Infection Group Specialized Register and a number of other areas and checked references for systematic reviews and relevant guidelines. They, in particular, chose randomized controlled trials of antibiotics versus placebo or no treatment in people with rhinosinusitis-like signs or symptoms, or sinusitis confirmed by imaging. Without antibiotics, 46% of patients with rhinosinusitis, whether or not confirmed by radiology, were cured after 1 week, 64% after 14 days, and they felt that antibiotics could shorten the time to cure, but only 5 to 11 more people per 100 would be cured faster if they received antibiotics instead of placebo or no treatment. However, they did note that 13 more people experienced side effects with antibiotics compared to the placebo or no treatment group. And therefore, what they decided was that the potential benefits of antibiotics was marginal and needed to be seen in the context of the risk of adverse effects. And considering antibiotic resistance and the low incidence of serious complications, there is no place for antibiotics for people with uncomplicated acute rhinosinusitis. This was another study published in 2008 by Young, De Sutter, Merenstein et al. And here they aggregated and analyzed individual patient-level data for all placebo-controlled randomized antibiotic treatment trials of adults that were conducted in primary care settings. They did exclude trials that used imaging or bacterial culture as part of the patient recruitment, and studies that were included did allow use of concomitant medications such as nonsteroidal anti-inflammatory drugs, decongestants, or nasal steroids, as long as patients in both groups had access to the same medications. They did exclude patients with severe symptoms such as high fever, periorbital swelling or erythema, or intense facial pain, and felt that those were risks for more complicated illness. Their results, they identified 10 such studies and completed an intent to treat analysis of the 9 double-blind trials. Using individual data, they found that the number to treat was 15. The finding meant that 15 patients needed to be given an antibiotic for 1 additional patient to be cured at 8 to 15 days after treatment commenced. Using statistical modeling, they determined that 64% of patients treated with placebo were cured at 14 days, compared with only an increase of 6%, 70% given an antibiotic, and only 1 patient out of 1,381 treated with a placebo experienced a brain abscess as a serious complication. Then they asked a number of questions. Do antibiotics benefit any subgroups? And they found that patients with a longer duration of symptoms, more severe symptoms, or increased age took longer to cure, but were no more likely to benefit from antibiotic treatment than others. They found that symptoms such as a previous common cold, pain on bending over, unilateral facial pain, tooth pain, or purulent nasal discharge did not have a prognostic value. Only 1 sign, that is purulent discharge noted in the pharynx on examination, was associated with higher likelihood of benefit from treatment, but the number needed to treat was still 8 in that group, and patients with symptoms for 7 days or longer were no more likely to respond to antibiotics than those with symptoms for fewer than 7 days. Their conclusions were that the meta-analysis provided a high level of evidence against routine treatment of sinusitis with antibiotics in primary care practice. Treating 15 patients with an antibiotic benefit to possibly benefit 1 patient 2 weeks after treatment did not seem like a good idea when one considered the cost and complications of antibiotic use. Diarrhea or other adverse outcomes were 80% more common among patients with sinusitis treated with an antibiotic than those treated with placebo. They also felt that current national recommendations to use an antibiotic for patients with a duration of illness of longer than 1 week was not to be recommended, as those patients presumably, they initially were making that recommendation as they felt that those patients were presumably more likely to have a bacterial infection. However, they found that the recommendation had been based on expert opinion, not on data, and that a longer duration of symptoms should not be a reason to prescribe an antibiotic for sinusitis symptoms. Finally, here's one in children. The purpose of the study was to evaluate the effectiveness of antimicrobial treatment for acute sinusitis as they're used in a community pediatric practice. And they looked at a total of 188 patients between the ages of 1 and 18 years of age, 10 to 28 days of persistent sinus symptoms. And they randomized the children to either 14 days of amoxicillin, clavulanate or augmentin, or placebo. They focused in particular on change in sinus symptoms as assessed by both the quantitative symptom score and subjectively by the parent. And secondary outcomes included adverse effects of treatment and recurrence or relapse. The results of the 161 patients who were included in the analysis, you can see 58 received amoxicillin, 48 received amoxicillin clavulanate, and 55 received placebo. Day 14 improvement rates were the same, basically, and the rates of adverse events were higher for amoxicillin than for either amoxicillin clavulanate or placebo. Relapse was also similar, as was recurrence. So their conclusion was neither amoxicillin nor amoxicillin clavulanate offered any clinical benefit compared with placebo for children with clinically diagnosed acute sinusitis. Their recommendation, and these are the recommendations as a summary from the Choosing Wisely campaign, do not avoid prescribing antibiotics in emergency department for uncomplicated sinusitis. Do not routinely obtain radiographic imaging for patients with a possible diagnosis of uncomplicated acute rhinosinusitis. And again, the American Academy of Allergy, Asthma, and Immunology, as well as the American Academy of Family Physicians and the otolaryngologists indicate, again, do not routinely prescribe antibiotics unless there are red flag symptoms. Finally, and let me just finish up with this, evidence-based guidelines for diagnosis and management of suspected acute bacterial rhinosinusitis have been put forward by a multidisciplinary expert panel of the Infectious Disease Society of America, and their guideline indicates the following, and I'll just summarize. Existing clinical criteria is unable to accurately differentiate bacterial from viral rhinosinusitis. There are gaps in knowledge regarding empiric antimicrobial treatment, even for acute bacterial rhinosinusitis. Changing prevalence and antimicrobial susceptibility profiles of bacterial isolates have been associated with this illness, and impact of the use of conjugated vaccines or the emergence of non-vaccine serotypes have also been found. They put together an algorithm and a guideline, which is noted in their summary. Here is their urgent referral criteria. The following clinical presentations are recommended for identifying patients with acute bacterial versus rhinosinusitis. And here they do say 10 days or onset of symptoms or signs of high fever, or worsening symptoms characterized by new onset of fever following an infection and initial improvement. Here are the references. So let me summarize now. Number one, no imaging for patients with low back pain except if complicating medical or psychosocial problems. Number two, no antibiotics in patients with acute viral sinusitis unless symptoms are greater than 10 days. And even then, they look for red flags or markers such as just mentioned. I will also say that if one is going to prescribe antibiotics, then there needs to be a clear indication that this is a bacterial infection, acute bacterial rhinosinusitis, rather than just the diagnosis of, quote, sinusitis, unquote. Finally, evidence-based practice means improved patient clinical outcomes, decreased harm, and improved cost-effective care. So with that, I'm going to say thank you. If you have any questions, I can be reached at j.kaplan@lcmchealth.org. I hope this has been helpful. We will have additional ground rounds coming forward associated with our Medicaid Managed Care Incentive Payment Project, promoting evidence-based practice and reducing low-value care work. Thanks very much.